Hey everybody, welcome back to the ECG of the day. My name is Reed. Before we get started, feel free to go down into the description of this video and download the PDF of this document so that you can follow along. And while you're there, like and subscribe to the channel so that we can keep making these videos. So let's jump into it. So the first thing I like to do when I look at ECGs is I like to look at the forest, and the trees of the forest are my QRS complexes. And so I might pick maybe a lead 2 down here, and I see I've got a narrow complex rhythm. Seems to be pretty regular, and that regular rhythm continues all the way to the end of the strip, so that's good. I notice that I have a narrow complex QRS, so that tells me that if I look at my heart diagram, that likely my QRS is being generated by flow through these His-Purkinje fibers, which gives me a nice fast QRS, right? It happens rapidly. And when I evaluate for atrial activity here, first thing I notice, obviously just eyeballing it, that there seems to be a little bit of baseline variability in the sense that there's not a whole lot of flat and then little P's and T's. And so before we jump into that, we'll look at the rate of this rhythm. And so I'll find a QRS that seems to end on a solid line. We'll maybe use this one just before it, and we'll say that's 300, 150, 100, 75, 60. So 60, roughly 60 beats per minute. So we've got a regular narrow complex rhythm at 60 beats per minute. So you would think typically these rhythms are typically kind of sinus rhythms, but as we look for what the atria is doing, I don't see organized P waves in front of my QRS. And what I do see, especially in lead 2 here, I see this baseline kind of wavy pattern that just goes back and forth and back and forth and back and forth. And so you guys are probably all very in tune with this. But when you have organized waves, in this case, right, this is atrial activity, because if you could see the amplitude of these, very small compared to my QRS, so the amplitude is small. And when you have these waves and the rate, if I could draw a line at the peak of this one and the peak of this one, the rate is a little bit less than 300 beats per minute. We can calculate that. So we've got 6 little boxes, so I like to do 1500 divided by 6. And so the rate of this beat to beat variation is 250 beats per minute. And so that's in the kind of the reference range of a flutter wave. And so these waves that we're seeing are flutter waves, specifically flutter waves that originate from the atria. So we've got atrial flutter. And so atrial flutter historically, or characteristically, is going to create this very regular kind of pattern, a sawtooth pattern, at a rate of 250 up to 300 beats per minute. And so that is what my atria is doing, and you can see, various, AVR has it. You get this nice pattern in AVR. Not every lead's going to have a perfect sawtooth pattern. It depends on the type of atrial flutter. Atrial flutter can happen in various different areas of the heart. Characteristically, if you look here, the tricuspid valve, which we know is between the right atria, which here's my right atria and my right ventricle. The tricuspid valve is historically where this reentry circuit formed, and you get little bits of reentry here. It could be clockwise, counterclockwise, and so that reentry around and around is what causes these waves of depolarization. It can also happen here in the mitral valve, not so often. And so we've got this atrial flutter, and now I need to figure out, how is my AV node responding, right? We can't really measure a PR interval because there's not a distinct P wave, but what we can measure for our AV node function is how fast is this AV node conducting the signal down. Because at the end of the day, the AV node in this rhythm is a bystander. We've got these flutter waves that are occurring, and they're sending waves of depolarization across the atria every time. And the AV node is picking up that signal and sending it down to the ventricles. But it can't do that every time. The AV node can't conduct at a rate of 250 beats per minute, and so you see here that it appears that every 4 flutter waves, the QRS responds. And so we can kind of count these out together. So maybe I'll pick this one. Here's first flutter wave. It's 2, 3, 4. And then we're back to the next set of 1, 2, 3, 4. You'll notice that the first flutter wave after a QRS always looks different than the rest. That's because that flutter wave is also superimposed on a T wave of the previous QRS. So make sure that you're looking for buried flutter waves as well. So this, as you can see, we have 4 flutter waves per QRS. And so we have an atrial flutter with 4-to-1 conduction, meaning 4 flutter waves per 1 QRS. And that tells me a little bit about my AV node's behavior. The next thing I'm going to do is I'm going to evaluate my QRS complex, because we can still do that here. I see that we've got a narrow complex QRS, right? If we measure that out, the QRS width is less than 120 milliseconds. My QRS axis, it's upright in lead 1. It's downgoing in AVF. And so we know that it's going up and to the left. My axis is going away from AVF, but it's still positive here in lead 2. So I would say that my QRS axis is somewhere in this kind of triangle between 0 degrees and negative 30 degrees. And so that's a left axis shift. It's a left shift in our axis. And we'll look at, maybe why do we have a left shift? We don't have any blocks. We don't have any hypertrophy. What I notice is that we do have, this is our little bit jumping ahead, but we do have poor R wave progression through the precordium. If you notice, my R wave isn't really growing very much through the precordium until I get to V5. It's finally upright. That's not very typical. And so as I start to move through, I'll just quickly check my QT interval. You want to find a QRS complex that seems to be not showing too many flutter waves, so you can see a nice evidence of that T wave there. That T wave doesn't look like it falls midway between, so I'm happy with that. So now back to this idea of my left axis shift. When I look for pathological Q waves, you notice here that V2, V3, I've kind of lost a little bit of those positive forces. And so there's even just a little bit of an R wave there, but I would say there's a pretty high chance that this person maybe had a prior anterior MI. Why do I say that? Well, if they've got a left shift in their axis, maybe that's because this anterior wall of the myocardium is unable to conduct, right? And that's kind of evidenced here by really their inability to create good positive forces in those anterior leads. And when I look for ST and T wave changes, I don't really see anything that's too prominent. No ischemic changes in the ECG, nothing that sticks out to me. And so the last thing I'm going to do is just put it all together. And what do we got? We've got an atrial flutter with 4-to-1 conduction at a rate of 60 beats per minute. Got a left axis shift and maybe prior anterior MI. We'll have to correlate that clinically. So I hope this helps. If you have any questions, throw them in the comments. Remember, with something like atrial flutter, really with any atrial arrhythmia, understanding that in a lot of cases the AV node is a bystander, right? So yeah, we have it in our algorithm here to look at the PR interval, but really what that represents is look at what the AV node is doing. And in this case we were able to understand how fast this AV node was conducting, right? And in this case it was conducting at a 4-to-1 interval, very fixed. So I hope this helps, and have a great day. See you tomorrow.